Hello, my name is Nona Patton, and this is my DMP project on opioid-induced respiratory depression in trauma patients receiving IV opioids. OIRD stands for opioid-induced respiratory depression and is a very serious life-threatening condition that can result in anoxic brain injury, cardiopulmonary respiratory arrest, also known as CPRA, mechanical ventilation requiring higher level of care, and even death. Opioids often effectively treat acute pain within the trauma population due to the pain from trauma, postoperative interventions, and therapeutic treatment, but this can come with the side effect of OIRD. Statistically, 90% of surgical patients and over 57% of med-surg patients are prescribed opioids for pain. A third of all CPRAs within the hospital setting are a direct result of OIRD. The survival rate of those who experience CPRA is only 29%, and 46% of those cases are considered preventable. On average, OIRD accounts for an increase in costs of $10,000 and an increase of length of stay of 5 days. Individuals who experience respiratory failure have a double mortality rate compared to MI, cancer, CVA, CHF, and renal failure. Those who experience respiratory failure have a 29 times higher mortality rate than those who do not. 64% of respiratory compromise is avoidable and related to knowledge deficits and recognizing patients at risk for OIRD and identifying respiratory compromise prior to an adverse event. The evidence-based approach includes recognizing and accurately identifying risk factors of OIRD, reducing adverse events, and improving quality of care, preventing significant events requiring understanding risk factors related to OIRD, and accurate monitoring and/or screening of the patients. A knowledge deficit of respective clinical guidelines is a common barrier in implementing best practice in healthcare. Nurses must be educated to improve understanding of medication side effects, risk factors of OIRD, and sedation. Working at a Level 2 trauma center that services the tri-state area, individuals of all aspects of the orthopedic trauma and neurological needs are treated. The trauma floor clientele includes motor vehicle accidents, assault victims, falls, workman's comp cases, gunshot wounds, and many more. These individuals often require surgical intervention related to the trauma or orthopedic needs, as well as the treatment of acute pain. The current practice on the trauma unit includes vital signs every 4 hours, if immediately, post-op, vital signs every hour for the first 4 hours, and then 4 hours following. Patients on the trauma unit can be prescribed a variety of analgesics, including oral or parenteral opioids, local continuous blocks, and patient-controlled analgesics. If the patient is receiving a PCA or IV opioids, a DORA tool must be completed prior to initiating or administration. If the patient triggers a high risk, then the DORA algorithm must be used to initiate continuous electronic monitoring and increase monitoring for vitals. The sedation scoring tool used on the trauma unit is called the DORA, Deaconess Opioid Risk Assessment. It incorporates the stop bank questions, and once that is filled out, you'll get a score. 0 equals no risk, 1 to 2 equals mild risk, 3 to 4 equals moderate risk, and greater than 4 equals high risk. If the scores are noted to be 5, a set of orders are automatically placed to alert the staff of high sedation risk, so physicians and nurses are aware and can adjust care as needed. Unfortunately, the DORA risk assessment is not utilized to its fullest potential and lacks consistency in use. Previous education grazed over the topic without explanation of the tool's purpose or the gravitational impact of OIRD upon this population group, therefore leaving gaps for misinterpretation. On the left-hand side, this is the DORA tool itself. These are the scorings that will occur when answered, and then this is the algorithm used. The purpose of this project was to appropriately identify risk factors of OIRD among trauma patients receiving IV opioids to improve implementation of preventative measures for early recognition of OIRD in turn preventing catastrophic events that led to increased length of stay, permanent damage, or death. The aim was to enhance the recognition of risk factors for ORID, improving compliance and accuracy of the DORA tool, and to follow the algorithm and implement ORID preventative measures on all high-risk patients receiving IV opioids. The algorithm includes continuous electronic monitoring for individuals receiving IV opioids that trigger a high risk for OIRD per the DORA score. The goal is to accurately identify risk factors, increase compliance with assessment of ORD, and improve initiation of interventions for ORD, in turn improving patient outcomes. This project is a quality improvement project designed to improve the current process related to IV opioid use. Continuous quality improvement requires proactive approach with improvement efforts to further impact the healthcare environment and individual behavior related to IV opioid administration. The quantitative method of data collection was used in the retrospective process. After analyzing the individuals who fit the inclusion criteria, further investigation took place to identify the compliance of the DORA tool with IV opioid administration and the accuracy of risk factors identified on the DORA tool. When reviewing the patient's chart, data was collected on adverse events that took place defined by code blue, rapid response team called, or unplanned ICU transfers. Further review included identifying high-risk individuals within the sample group and if the algorithm was followed for continuous electronic monitoring. This information was statistically reviewed pre- and post-educational intervention to determine if the education regarding risk factors of ORID, interpretation of the DORA tool, and evidence-based guidelines with IV opioid use in the hospital setting improved the compliance, accuracy, and identifying high-risk patients, improving patient outcomes. ONTCC's clientele often receive IV opioids for treatment of pain, placing them at a higher risk for OIRD. The unit-specific data reflects more than 60% of adverse events were related to respiratory compromise. The benefits of this project include decreasing costs associated with higher level of care requirements, decreasing length of stay, improved patient outcomes, provide a sustainable foundation for OIRD prevention. The proposal is to increase the accuracy of identifying risk factors, increase compliance of assessing the patient with each IV opioid use. Through the adherence and precision of the DORA tool, the primary RN can monitor the patient effectively, placing continuous electronic monitoring on high-risk patients and improve interventions initiated. With these quality improvements made within practice, patient outcomes improve. Deaconess Hospital is a learning hospital providing clinical rotations to students, opportunities for growth, and extending support through school-based projects. There's a nursing evidence-based practice and research council within the health system who offer guidance, education, and consultation on evidence-based practice research. The knowledge to action model was used for knowledge translation and dissemination into practice, providing a foundation for sustainability. The knowledge to action model was used as a framework to implement the process. This model was used to bridge the gaps from knowledge to implementation. As demonstrated in the figure shown, the model is strategic and is often described as a funnel for synthesizing information. This model starts with identifying the need and adapt knowledge, identifying barriers and facilitators to knowledge use, tailor and implement strategies, monitor knowledge use, evaluate outcomes, sustain knowledge use. Through these steps, I was able to implement and disseminate the information and sustain the project. The population intervention comparison and outcome, also known as the PICO question, is as follows. In adult trauma patients receiving IV opioids, does an educational intervention for staff on guidelines and evidence-based practice related to opioid-induced respiratory depression compared to no education improve accuracy and compliance of the Deaconess opioid risk assessment to identify risk factors related to respiratory depression and intervention? A thorough search of literature was completed to retrieve relevant publications to support this quality improvement project. The filtered search criteria were limited to full-text articles from academic journals and dated publications ranging from 2016 to 2021. Utilizing Maryville University Library, the phrases used for search were respiratory depression and opioids, monitoring respiratory depression, monitoring respiratory compromise, and adverse events in opioid use. Although each phrase retrieved several articles, only articles pertaining to opioid use was used for the literature review. Through the literature review, several themes emerged. The themes included respiratory depression related to IV opioid use, monitoring and/or screening before and after IV opioid administration, and lack of knowledge of identifying and managing respiratory compromise. To expand on these, postoperative patients often go undiagnosed for OIRD due to the transition of care from PACU to floor. There are different screening tools when identifying risk factors and scoring throughout different facilities. The Stop Bang questionnaire is often and widely used. The research did reflect 64% of respiratory compromise is avoidable and related to inadequacy of initiating appropriate interventions, related to lack of knowledge on recognizing respiratory compromise, and lack of understanding when interventions should occur. Within the literature review, there were strengths, weaknesses, gaps, and limitations of each study. To summarize, the strengths included the credentials of the researchers, all including MD or PhD. Weaknesses, gaps, and limitations include most studies utilizing a retrospective design, limiting the causal effects of interventions, lack of detail interpreting respiratory compromise, inconsistency of the respiratory rate threshold for respiratory depression. Some studies reflected less than 8 and others less than 10. Grohl and Grimshaw created a theoretical framework for changing behavior, describing the best method of implementing change is by reviewing the best practice strategies in change implementation and transitioning evidence-based clinical guidelines into practice. The framework for changing behavior bridged the gap found in multidimensional setup of organizations and provides translation of the research and knowledge into practice. Transitioning the evidence into practice requires changed behavior and culture of the staff. This was best accomplished through this framework. Recognizing and accurately identifying risk factors for ORID is necessary to prevent adverse events defined as unplanned ICU transfers, rapid response calls, and code blues. Therefore, the proposed goal is for each trauma patient receiving IV opioids be accurately assessed for OIRD with each administration using the DORA tool. ONTCC has been identified as the highest rated nursing unit for adverse events. Therefore, an opportunity for improvement exists for an educational intervention on evidence-based practice guidelines related to OIRD risk factor recognition and prevention. The methodology used includes a retrospective study design, reviewing 154 charts to meet the minimum standards for the comparative statistical analysis using the Z-test. The inclusion criteria includes ages 18 through 89, regardless of gender, all patients to be admitted through trauma services, and have IV opioid administration during their stay. The exclusion criteria is under 18, over 89, and not having IV opioids administered. The CMS guidelines include requirements for hospital medication administration, particularly IV medications, and postoperative care for patients receiving IV opioids. These guidelines were used to provide evidence-based information as a foundation for the changes necessary to provide safe and reliable care. The education was disseminated to the nurses on ONTCC. Evidence suggests recognizing and accurately identifying risk factors for OIRD reduces adverse events. A knowledge deficit of respective clinical guidelines is a common barrier in implementing best practices in healthcare. Knowing this, education among nurses is imperative for improvement. Nurses must be educated to improve understanding of medication effects, risk factors for respiratory depression, and sedation. This slide represents the planned step-by-step process to disseminate the project, demonstrated in steps 1 through 5. First, IRB approval, then a report of trauma patients was electronically generated by the trauma services manager. Step 2, the initial retrospective review. Step 3, provide educational intervention. Step 4, another report was generated by the trauma services manager and a post-intervention chart review was to take place. And step 5 was analysis of the information. The data collection sheet used pre- and post-educational intervention is displayed on the left lower corner, reflecting how data was converted into a binary data set, 1 for yes, 2 for no. This allowed for only personal information to be reviewed and not collected. The data compiled was analyzed using the z-test to compare pre- and post-intervention efficacy. The descriptive statistical analysis goal is for the ration to go up on completion and accurate DORA scoring and the ration to go down on adverse events among patients receiving IV opioids. SPSS was the system used for analysis. The budget expectations were minimal and is displayed on the table to the right. Individual support through the project includes Dr. Rachel Davis, who is the chairperson and a supportive resource for guidance and constructive feedback, Dr. Boniface Stegman, who is the committee member providing support in the written documents, Dr. Lois Sweden, who is the expert in research studies at Deaconess Hospital and has years of experience in implementing evidence-based practice changes in the hospital. Further support comes from the Trauma Services Manager, Dara Dilger, who provided reports specific to the project, and ONTCC Unit Manager, Courtney Ratcliffe, who provided the space and material to conduct the research on ONTCC, and accountability to staff to complete the educational intervention. The Nursing Evidence-Based Practice and Research Council is a committee that provides oversight for all research programs approved. This is the projected timeline extending from July 2021 to July 2022. CMS guidelines led the educational intervention, enhancing the knowledge and encouraging internal motivation for change. The statistical significance for compliance and accuracy showed true change from pre to post education, indicating an overall improvement in identifying risk factors for ORID. The alpha error of probability is 0.05 or 5%, reflecting internal consistency and reliability. The data collection tool identified the specific variables of measurement to ensure validity. 2 separate reports of trauma patients were run with particular timeframes to capture pre- and post-intervention. An exemption status was obtained through IRB by ensuring the data collection process met standards. HIPAA was followed during the project, and the retrospective chart review prevented any conflict of interest in care provided to patients. The methods to ensure data quality and accuracy included upholding the reliability and validity measures. The reports run for specific timeframes that prevented intertwining data collection pre- and post-educational intervention. The instrument aligns with face validity, adequately capturing the construct of education and improving the recognition of ORID risk factors. Quantitative method reflects the nominal data collection used for the independent variables, 1 for yes, 2 for no. DORA compliance, pre versus post-intervention, showed an improvement from 56% to 82%. DORA accuracy, pre versus post-intervention, improved from 35% to 75%. Adverse events reflected 5.1% pre, decreasing to 0% post. The data for adverse events was insufficient to run statistical analysis, but reflected an improvement pre versus post-intervention. The power analysis provided a degree of variability through the calculated required estimated sample size to reduce the likelihood of type 2 errors and strengthen the data results. The calculated power for both accuracy and compliance yielded a strong study. The p-value for both compliance and accuracy was less than the significance level, therefore proving to be statistically significant. Compliance increased by 26% and accuracy increased by 40%. The IRB approval occurred in November of 2021, delaying the request for the pre-intervention report to begin data collection. There was a delay in receiving the report as well, which was acquired in January of 2022, setting back the intended time frame for data collection. The chart review was conducted in May of 2022. This chart reflects the results for accuracy and compliance of the DORA tool and provides numerical representation of the improvements. The adverse events that occurred pre versus post intervention showed an improvement, although they lacked enough data to indicate a statistical significance. The chart displayed breaks down the 4 adverse events noted during the pre-educational intervention data collection. This chart reflects a breakdown of the data for inaccurate DORA screening. This separates the inaccurate DORA assessments into categories of incomplete assessment versus incorrect data recorded on the assessment. This showed an improvement in both incomplete assessments and inaccurate data when comparing pre- and post-intervention information. This chart reflects further analysis into the inaccurate data for the DORA questions. The total IV opioid administrations were 199 administrations in the charts reviewed prior to the intervention and 178 administrations in the charts reviewed after. This categorical data tracks common themed errors among the questions, evaluating the effect of the intervention on accuracy and determining if the education enhanced the understanding of the risk factors for ORID. This figure reflects the improvements in each category per administration after the education. The project strengths include the project design, the evidence-based practice guidelines used for the education, and the decreased bias through computer-generated reports in the data collection process. Project limitations include staff turnover from pre to post-intervention, lack of supportive evidence, and the improvement of adverse events, and the literature review limited in education as an intervention. Generalizability refers to the ability to use the results in other situations or studies, which is reflected in this study by the potential to impact other population groups such as postoperative, outpatient, or critical care setting. Sustainability refers to the ability to maintain a change, which is achieved in this project through providing continued education of the DORA tool, which is a cost-effective implementation process that benefits quality care and patient outcomes. Barriers encountered while conducting the project were predominantly related to hindrances through time constraints. One obstacle was obtaining the report containing the list of trauma patients provided by the Trauma Services Manager pre-intervention data. It was delayed by 6 weeks and required an adjustment of the original project timeline. This created an impact on the educational intervention by eliminating any discussion on the unit-specific examples related to DORA tool or adverse events. This intended purpose of including the unit-specific information was to expand, amplify, and clarify understanding of the educational information. The post-interventional data report obtained from the Trauma Services Manager was also delayed due to staffing concerns, causing a delay in logging the trauma patients into the system. The facilitators in this project, both internal and external, include the organizational structure by encouraging research projects, and unit-based leadership by supporting and encouraging the process, as well as providing any resources required. The unit nurses, who played a pivotal role in facilitation, and the informatics infrastructure, allowing technology to positively impact the data collection process. Clinical practice and future research is encouraged as the project results reflect the need for continued education with staff to lay the fundamental groundwork for expectations and care. The project opened the door for future research in the preventable adverse events related to respiratory compromise and emphasizes the significance of education as a key element in the transformation of quality care processes. Healthcare policy is affected by validating the necessity for educational initiatives to optimize quality care among high-risk patients and decrease negative outcomes. Quality and safety is affected by the basis of standards of care. The significance of OIRD among trauma patients is denoted by acknowledging all OIRD cases are preventable and can lead to critical consequences with potential life-threatening implications. The educational intervention utilized within the project focused on evidence-based guidelines which correspond with delivering safe and quality care. To recap, the project results provided significant evidence that implementing the educational intervention improved the recognition of risk factors related to OIRD. The outcomes showed an increase in the accuracy and compliance of the DORA tool after using evidence-based guidelines to provide education on OIRD. The project's findings of increased accuracy and compliance in the DORA tool reinforces the concept that evidence-based education achieved the proposed objective of improving recognition of OIRD risk factors among trauma patients and reducing preventable adverse events. The elemental aspect of improving the accuracy and compliance of the DORA tool established expectations aligned with the highest standards of quality patient care and outcomes. Disseminating the evidence-based guidelines through education was the primary process for communicating the anticipated change and was the fundamental principle in this process, making the interventional strategy chosen in this quality improvement project critical to the project's results. The relationship between adverse events and compliance and accuracy of the DORA tool is unclear, and further research is needed to provide inference. The following slides are references to the project.